your ability to, I'd say, categorize the types of denials. Like if we want to hover there for a minute, because
Sure.
there are multiple denial categories. Some denial categories will run a higher risk of a future write off than others. Some are more, they're just a drag on resources, right? If you get an additional documentation request from a payer, that's a drag on a resource. So that means there are more steps we're going to have to follow on the back end of the revenue cycle process, but we're going to get the payer that additional documentation. And then, assuming they don't find a reason to deny otherwise, they're going to pay the claim. But if you get a prior authorization denial, meaning you either failed to procure the authorization prior to the service, or you procured the authorization for a certain CPT code, but then when the service was actually provided, a different code was billed out, or there are myriad of reasons why you could get a prior auth denial. And a lot of times those denials are upheld and are going to result in a write-off if you don't get it perfect on the front end. Or medical necessity denials. Those are really complex, and sometimes it requires peer-to-peer, physician to physician on the provider side and the payer side to really wrestle with, did this particular service or test meet medical necessity requirements under that particular patient's benefits? So you really have to understand the data. You need to have access to clean, actionable intelligence. You need to have individuals in place who are really good at interpreting that type of intelligence. And then you need to organize your teams within revenue cycle and with tight connectivity to the clinicians. So your managed care team, those are the individuals who negotiate the contracts with our payers. You have the clinicians who are the ones documenting the care or submitting orders for services, et cetera. You need a lot of connectivity between these other stakeholder groups and a lot of cross-team collaboration to prevent these denials in the first place.
So are denials, that whole world you just described, would you say that's the sort of squeakiest wheel in the system? Is it the thing that you presents the most potential for improvement?
Yeah, I'd probably say it's the bane of my existence. And if you asked any revenue leader in the healthcare space, they'd probably tell you the same thing. It can sometimes feel like a game of whack-a-mole because just as you build out a system or a remediation plan that would prevent a particular denial category, the payers are going to come up with another way to deny you. And so it's constantly shifting. It's a very hard metric to move, but it is movable at the same time, right? It just requires an enormous amount of focus and energy. Um, and, we've within this industry, we often say it's like the battle of the bots because you have payers who, for the most part, have adopted automation techniques at a much faster clip than most providers or health systems have. And so, without any human intervention at all, they can deny thousands of claims automatically. And they come at you like a tidal wave within a business office. And then you're often caught trying to figure out, okay, I don't have the staffing for this. All right, let's look at our EHR. Are there any ways to impact the build of our EHR so we can automate certain steps? Or the rules might change. I talked about additional documentation requests earlier. Well, those rules change all the time, and they're not even easy to find at the payer level. So sometimes you have to wait until you experience a pattern with an ADR or some additional documentation request or whatever that might be. You wait till you experience the pattern and then you try to build your own automation to address that new pattern.